My name is Anthony Caffarelli. I'm the Newkirk Family Endowed Chair in Aortic Care, as well as the Director of the Matranga Aortic Center and Director of Hoag Cardiac Surgery. I want to welcome you this afternoon to join us in a very special event. It's an opportunity to bring our community of aortic patients, family members, healthcare providers, and our Aortic Center team together to celebrate a very important day. Aortic Awareness Day is always done on September 19th. This is our third annual event here at Hoag. And the objective is really think aorta, because aortic emergencies, including dissection, ulcers, rupture, they're fatal. And so what we need to do is diagnose these early and get people to centers that specialize in this. Fortunately at Hoag, we've got an incredible team designed to handle this. This day would not be possible without our donors. And so for that, I want to first thank our donors. Elaine and Robert Matranga, thank you very much. Your philanthropic gift has helped us name the center in your honor and do some very amazing things for patient education. Martha and Jim Newkirk, you're the family that's donated my chair. And with that, we've been able to bring two groups of teams back to Houston for our aortic symposium. We were there last year when COVID really hit, and we brought the team back, kept everybody safe. And Jack Harold, I want to thank you very much. Your philanthropic gift, which you've expanded from the aortic program and now to all of Heart and Vascular Institute, is going to allow us to do some very amazing things. And then obviously the Hoag Hospital Foundation Innovators has allowed us to do the startup for our essential connective tissue disorder clinic that Dr. Liang and Meg Boglin run. You'll hear more about that in a little bit. This third annual event, our first year was phenomenal. Last year, due to COVID and social distancing, we had to make it virtual. And because of the Delta and Mu variants, we're back social distancing again. So we've all dealt with the Zoom meetings. Here's a little joke to explain that. Some of you have dealt with this with our telehealth visits over the past year and a half. So I appreciate your patience. We're not really computer folks. We're pretty good in the OR, but Zoom calls we're learning. So with that, thank you for your patience. And I think this has helped out, and you'll see this more in the future for certain meetings. Before I get into what we've done over the past year, I really want to thank our team. I get to work with an incredible partner, Dr. Assan Shah. He's allowed us to expand our role with the Aortic Center and really cover aortic dissections and emergencies from all around Southern California. It's not just me. So with that, thank you very much. Also, Dr. Liang coming down from Stanford and really enhancing our program to take care of the Marfan's patients and other patients with connective tissue disorders and their families has been incredible. He's been a mentor of mine since my early days at Stanford, and every day I get an opportunity to learn more from him. With that, we've got Rita Weiss, our nurse practitioner, who I'll introduce a little bit later, and then Meg Boglin, who's essentially David's Rita, and she handles all the connective tissue disorder patients. In addition, we have our vascular surgery colleagues, Dr. Lindsay, Dr. Nabi, and their new partner, Dr. Faruqi. Dr. Puckett retired last year, so I hope he's out there fly fishing somewhere, and he can watch this later. Our administration, they've been phenomenal in allowing this aortic center to progress. And then we have some new team members that we're going to introduce today, and I'll talk about them shortly. But when it comes to the aortic emergencies, we've got our first responders that bring them into the emergency room, our emergency colleagues that make the diagnosis. Then we have our operating room staff, our cardiac anesthesiologists, our cardiac surgery OR nurses, our perfusionists, the CV techs, then up in the ICU nurses, the respiratory therapists, the physical therapists, occupational therapists, and then our ninth floor nurses. A huge team, and including the cardiologists and every other consultant out there that helps take care of these very difficult patients. We've got a great team. It's an honor to try and lead everyone, and I learn from everybody each and every day. So with that, thank you very much. You provide me great joy, and it's a privilege and honor to take care of everyone here, and I take that very seriously. So thank you. With that, let's look at what we've done over the past year. Obviously, we can't go into that without talking about COVID. Started as COVID-19, now we're into 2021. It's impacted elective surgeries. You know, we were able to scoot by most of 2020 without major issues, but then it really hit California towards the end of in December, and then January, February of 2021, we had to postpone patients that were considered elective, and we still handled emergencies. We got a lot of emergencies, but unfortunately, because the hospital was so full of patients with COVID, we couldn't accept transfers. So that meant aortic emergency patients didn't get the care they needed. So little plug to get vaccinated. It's not a political issue, it's a science issue. So let's get that taken care of. Our aortic clinic, we've had some ups and downs. As far as staffing, COVID's affected that. And then we had some roster changes. I believe the roster we have now moving forward and some of the new additions, we're going to be able to streamline care a little bit better. Through the great gift by Jack Harold, and then expansion of his gift from just the Aortic Center to all of HVI, we've been able to purchase a second force CT scanner. You see that pictured here on the right. That has, a lot of you have gone through the scanner in the hospital. This one's going to be put in the outpatient setting over near the 510 building, and that'll be able to streamline patients' access to getting the right imaging that they need. And with that advanced imaging, that allows us to determine, is this an aneurysm that we should still follow, or is it reached the point that elective surgery outweighs the risk of watchful waiting? So this is a big deal. It should be ready by Q2 2022. And I think it's going to benefit a lot of patients, not just aortic surgical patients, but all of patients with heart and vascular issues. We have new aortic team members that I'd like to introduce. With that, we have Chelsea Weatherill. She's a genetic counselor that's worked at Hoag. She has a passion for aortic disease from her training. I'm going to let her explain a little bit of that, but she's been joining us on Thursday and Friday. Not just is she addressing aortic patients, but also addressing other patients with heart and vascular issues such as hypertrophic obstructive cardiomyopathy and others. So she's got a great talk lined up for you towards the end of this, and I think you're going to learn a lot. I definitely did. Imad Faruqi is joining Dr. Lindsay and Dr. Nabi's vascular team. He's well trained out of USC, and I've had an opportunity to work with him, so I look forward to working more. Dr. Timothy Lee, pictured on the right, he's our new hire at Newport Cardiac and Thoracic Surgery. He'll be joining us on October 1st. Now we're going to have a complement of 3 aortic surgeons to handle all of your problems. So Tim will be joining us in a couple weeks. So I'm looking forward to him getting here. In the next upcoming year, we've got some exciting times. We've obviously can't do any of this without technology, and a lot of this is only doable because of the philanthropic efforts of our donors. The first thing, we're going to be looking at wearable devices to optimize the performance for our aortic team healthcare providers. There's been a lot of talk about physician nursing burnout. COVID's brought that to the forefront. There's not been a lot that people have suggested to do about it. This is going to be a wearable device that's going to allow us to access our own individual data and make personal choices to achieve optimum performance. That's going to be rolling out shortly. We're also exploring an artificial intelligence platform that will help our radiologists in recognition of aortic emergencies. It was recently approved for aortic dissections last month by the FDA. It's got a long track record with the stroke patient population over the years, and we're looking to be one of the first centers in the country to take part in their aortic program. It also has a platform that allows direct communication with physicians, the ER colleagues, the radiologists, the cardiac surgeons, the vascular surgeons, and allows us to access the imaging all in a HIPAA compliant database. So exciting, and definitely would streamline care. And as a lot of you know, and family members out there, time is of the essence when an emergency occurs. We've been talking the last several years about the aortic database. We've made significant progress. We've had to be tied up a little bit with our negotiations with Providence, and with all the legal matters, we're finally getting closer. We're obviously adding new staff members to the Aortic Center, so you're going to see some new friendly faces. They've all been vetted by us. We're very happy that they're joining our team, and we look forward to making your patient experience the best. We're also in the creation of a aortic number for regional aortic emergency referrals. So instead of going through our typical transfer center here at Hoag, trying to streamline that process for outside emergency rooms to get patients to the right care that they need, that we can provide. So with that, I'm excited for where we've come and where we're going. I'm glad you're part of it. I wish we were in person so I could see everybody live, but hopefully next year we're going to get there. So thank you for doing your part. With that, I want to introduce Rita Weiss. I don't know that Rita needs any explanation, but to introduce Rita, she's been with us for 4 years. She's a phenomenal nurse practitioner. She manages myself and Assan very well. She takes care of you guys. She's there to answer your phone calls. She's kind of the den mother of the whole group. So we couldn't do any of this without Rita. We're proud to announce she's going to be the director of the Matranga Aortic Center from a nursing standpoint. And with that's going to bring on some responsibilities that are going to be new, but I assure you she's going to knock it out of the park. So with that, I'm going to turn the mic over to Rita.
Thank you, Dr. Caffarelli. So I have to start off by saying I aorta tell you thank you for the 3rd year in a row. Thank you for being here at Hoag Aortic Center's 3rd annual Aortic Symposium. Physical distancing has changed the way we work, live, gather, and celebrate. Virtual events, telehealth, text messaging has become our new reality. Despite this, our aortic center has been busier than ever. When I first started 4 years ago, we were at 650 patients. Now, because of your great experiences, great outcomes, and word of mouth, we have grown to nearly 1,900 patients, which is amazing, which is why we're adding new staff to help us. Despite the profound negative impacts of COVID, I have realized the sense of unity in this aortic community. There wasn't a week that went by that I didn't feel your sense of gratitude. The messaging, the letters, they sometimes kept us going for days. It was great to hear when you caught your first wave post-aortic dissection, when you lost the 10 pounds that COVID put on, that you had your first grandchild, the trust we formed chatting over the stress of the pandemic, whether to get that vaccination, how to get your family vaccinated, the concern you had for our team about our supplies, how our emotional health was. We really appreciate you guys caring. The best message I got this year was that of service. When is Hoag going to open? When can I give back? When can we come and unite again? Unity, gratitude, thoughtfulness, and service is what has created the culture in this aortic community, and I thank you. I'm so grateful to be a part of it. A good leader can lead them to water, but a great leader can make them drink. Hoag would not be successful throughout this pandemic without our sensational leaders, Tony Caffarelli and Assan Shah. Thank you is not even enough to express the gratitude and the endless call nights and the nights even when you weren't on call and had to go in to help put COVID-19 patients on ECMO, to help support the ICUs. We can never thank you. Your families won't forget your absence during this time. So we have to thank them. Jen, Ty, and Kate Caffarelli, thank you. Julie, Caden, and Amina Shah, your dads, your husbands are heroes that put others first and sacrificed your family's time while serving others throughout the pandemic. They would not and could not be the same without your support. So thank you to your families. I also want to recognize our dedicated vascular surgeons who once again claim national recognition for their clinical excellence on abdominal aortic aneurysm repair. Thank you, Dr. Stephen Lindsay, Dr. David Nabby, and Ahmad Farkoui, their new associate. Special thanks to John Puckett. Your service to Hoag Hospital and our aortic community will never be forgotten. Enjoy your retirement. Aortic Awareness is the day to celebrate you. Aortic dissection is a rare and life-threatening emergency. It requires early diagnosis to prevent mortality. The incidence rate is 3 per 100,000 per year. That's why it's hard to diagnose. It's rare. It can be a challenge to diagnose because it mimics other differential diagnoses, such as heart attack, pulmonary emboli, GI upset. Mortality rate is 1 to 2% per hour once symptoms start. Diagnosis is essential in management. Hoag has had 100 aortic dissections over the last 7 years. So when we're all meeting, we usually have the aortic dissection survivors stand up. So I want everyone at home to stop. And if you're an aortic dissection survivor, please stand up. And happy aortiversary. We are here to celebrate 1 year. The journey of 1,000 miles begins with a single step. I also want to celebrate those that have planned that had planned surgeries. This is also your 1 year aortiversary. And finally, I'd like to pause and let's reflect about those that didn't make it, about the calls we couldn't take, especially during the pandemic when our hospital beds were full. We're going to take a moment of silence to remember those that passed from aortic dissection. The first responders have been putting their lives on the front line to help those in need throughout the pandemic. Thank you for your courage and your bravery. Hoag has piloted our first class to educate the first responders and EMTs in the community. They aorta know the signs of aortic dissection. So we are out there as we start to open up with COVID. We're going to start to do more community classes with the EMTs and the ERs so that we can get everybody thinking aorta. Because the more people we can teach about the risk factors, the better we are going to be at diagnosing them. And if the EMTs are planting the seed for our ERs, then we're going to all be successful in creating this initiative to think aorta. Thank you to all our first responders and their families for their selfless dedication to our community and Hoag Hospital. Please enjoy the slideshow of some of our amazing first responders. There is truly no place like Hoag. Without further ado, I'd like to invite Dr. Assan Shah, the co-director of cardiac surgery. He's the yin to Tony Caffarelli's yang. You can't have two yings or two yangs, so he's a great balance for our program. Assan?
Thank you so much, Rita. I really appreciate that. And it was great seeing those pictures of everybody together. I'm really excited to be here today, even though it's virtual. I know we have hundreds of people out there listening, so we're all very excited to have you. So I wanted to talk a little bit about more specifically kind of the surgeries and therapies that we do here at Hoag to help people with aortic disease. Next slide here. Yeah, so since 2015, we've been really busy. So we've done about 286 thoracic aortic aneurysm replacements. We've done 100 type A aortic dissection repairs. And again, aortic surgery is not the most common thing, so these are very high numbers. Just looking at last year, even during COVID, we did 43 elective, meaning kind of scheduled thoracic aortic surgeries with a 0% mortality rate. For our sicker patients, the urgent emergent cases, we had 26 of those with a 3.8% mortality rate. In terms of the patients that we operate on, looking at everybody, the median age was about 63 years old, and about 30% of our patients were female and 70% were male. Looking at aortic dissection in particular, we've been steadily busy for 7 to 10 years here. Last year we did 16 type A aortic dissection repairs, and any center that does more than 13 is considered high volume. We've done 84 total cases since 2015 with an operative mortality of about 15%, which is much lower than the national average of about 20 to 30%. And I wanted to talk a little bit about some of the surgeries that we do to treat aortic aneurysms and dissection. Before I start that, it's a good idea just to have a little bit of a gist of the anatomy we're talking about. So the first part of the aorta right after it leaves the heart is this aortic root right over here. It's kind of where the coronaries come off, where these little bulges, the sinuses. Then the next part up here is that straight kind of ascending aorta. Then the part at the very top kind of curving around, which gives off these branches of blood vessels to your head and arms. That's aortic arch. And then the aorta coming down from the top of your chest essentially to your belly is the descending thoracic aorta. So starting at the first portion, so if someone has an aneurysm right at the very beginning part of the aorta after the heart, it's called a root aneurysm. And again, that area encompasses these little coronary arteries and the aortic valve itself. So kind of the standard way to replace a root aneurysm is, we cut out the diseased tissue, we spare these coronary arteries, meaning we keep them intact. We replace the valve as well as the aorta with a graft. And these days, this usually comes together as one piece. And we sew that all together. We sew it to the other end of your aorta, and then we reimplant your coronary arteries. And then we, reperfuse or give, that part of the aorta blood back. And that's what it looks like in the end after repairing a root aneurysm. So that's called a root replacement, or it's named after someone, or Bentall procedure. If it was so some patients, their aorta is enlarged, but the actual valve is normal and functioning well. So in those sorts of cases, we try to spare the patient's native valve if possible. And that procedure is called a valve sparing root replacement. And in that procedure, we remove the diseased aorta, again, save the coronaries, but we keep the valve intact and sew in a prosthetic graft around the valve, and then sew it all together. Going up to the next part of the aorta would be the ascending aorta. That's more of the kind of straighter tubular portion after the root, but before the arch. And then for surgery for that, again, we open the chest, we stop the heart, we cut out this diseased section of the aorta, and we replace it with the tube graft, which is kind of made of a woven polyester material. And this is our simplest aortic procedure to do, just an ascending replacement. So coming up and around next would be the aortic arch. This is a more complex region to replace because you have all these major blood vessels coming off, going to your brain and your arms. Fortunately, isolated arch aneurysms are not as common as the ascending and root aneurysms that we see. But during this surgery, again, we cut out this whole diseased part, and here we have to put individual grafts or branches of this graft to those head vessels and arm vessels. So coming down, next area would be the descending thoracic aorta. If someone has an aneurysm here, the kind of classic or kind of old way of repairing this would be we'd open the chest from the side, remove that diseased aorta, and again sew in one of these prosthetic tube grafts. But with current technology, oftentimes we're able to replace these kind of minimally invasively over the stent. So instead of having to have any incisions on the chest, we can just put a couple small punctures in the femoral arteries in the groin and bring up a kind of a covered stent and land it inside of that aneurysm. So now the blood will flow from your normal aorta through this prosthetic tube or stent, avoiding the aneurysmal area, and then kind of be released to the rest of the normal aorta down here. And that's called TEVAR, or thoracic endovascular aortic repair. And then lastly, I just wanted to touch on how we repair a type A aortic dissection. So this is a more complex operation compared to just a simple aneurysm repair. This is sort of the CAT scan we oftentimes see. So that yellow arrow is pointing to the aorta. You can see it has that little zigzag or kind of tear in it. So some blood is going through what we call the true lumen, or where it's supposed to be. And then some blood is going through the false lumen, or where we don't want it. And what that looks like in real life is this. So down here is kind of the heart, and this purple thing is the aorta, and it's not supposed to be purple. It's supposed to be kind of yellow or tan. So it's kind of engorged, inflamed, enlarged, and potentially about to burst. So what we do is we remove all that and we replace it with one of those grafts, which you see right here. And most of the time, because the tear can extend all the way from the heart down to the patient's legs, we remove and repair the life-threatening portion of it, but we do need to at least stabilize the parts that we sew to. So we repair those torn layers of the aortic wall. There are different ways to do it. In this picture here, we use kind of felts, which is kind of like a kind of firmer cloth sort of material, and we sew some of it outside the wall and some of it inside the wall to kind of give that native aorta some more strength before we sew that graft to it. And then lastly, how do we sew this stuff? Well, in some ways it's very simple. Essentially, it's sort of needle and thread. So we take the prosthetic tube graft, which we get off the shelf, and we sew it to your own aorta using suture. And we kind of sew it around this way and bring it around, and we tie a knot and then release the blood flow. So relatively simple repair. Now the blood can go through the graft, through the aorta, down to the rest of the body. And that's all I had for today, but I do want to introduce David Lang, who'll be speaking next. David Lang is a cardiologist in our aortic center. He's internationally known for his expertise in Marfan disease and connective tissue disorders. So David.
Assan, thank you very much. This is my third Aortic Awareness Day with Hoag. This is the second anniversary of the initiation of the Marfan program at Hoag through the generosity of the Hoag Innovators Program and the continued support of our philanthropists. It's been a wonderful experience. And although aortic surgery and aortic procedures are key to the success of an aortic program, I think what I find valuable and wonderful about Hoag is an understanding that caring for the aortic patient isn't just the operation. It's really about caring for them before, diagnosing them, managing them, reassuring them, and then caring for them and making them a part of our family afterwards. So, and I think that was the philosophy that began the Marfan program here at Hoag. So it's been a wonderful 2 years, been growing gradually. We've been added another member to our family. Meg has been with me from the start. She's our nurse navigator, and we recently added Chelsea Weatherill, who is a genetic counselor, who adds another level of expertise, and she'll be talking to you shortly. The exciting news is next year, as we grow, we'll be the host, Hoag will be the host for the annual Marfan Foundation Conference. So it'll be the first one in person for the last 3 years. So it should be a big one. We're hoping to have 600 or 700 patients from all around the country and all around the world with Marfan syndrome, along with their families. And in addition, we'll also have the experts from around the world and around the country in Marfan syndrome and all these related conditions. It's a very unique conference. Go forward. Here we go. So it'll be July 7th to the 10th. It'll be hosted at Hoag as well as the Marriott in Newport Beach. It's a unique conference in that it's one of the few times where not only will you see patients, but you'll see the world's experts all together. And it's a unique opportunity for patients to get to know each other, to interact, be with people that share their experiences but in addition, an opportunity to be face-to-face and one-to-one with the world's experts on Marfan syndrome, on Loeys-Dietz syndrome, on Ehlers-Danlos syndrome. It's a unique experience, not only there one of bonding, but one of education. And I'd encourage you all to join the Marfan Foundation, and certainly Hoag. We're very inclusive. It doesn't mean you don't have to have Marfan syndrome to be at the conference. If you have a shared experience, and many of you do, because aortic disease is a big part of Marfan syndrome, then you're welcome. And I think you'll enjoy the conference. And with that, I will hand this over to Megan Boglin, who's the Center Nurse Navigator. Many of you know her. She's the face and the voice that many of you meet first. We'll introduce you to another one of these initiatives that will be starting this year.
Hi, thank you, David. Yes, I'm Meg Boglin. I'm the Clinical Nurse Navigator for the Marfan and Related Conditions Program. I'm here to talk to you about a very new, exciting program for our aortic center support groups. So our patients have asked for a very long time, are we going to be able to have support groups? So I'm very excited to say, yes, we are starting support groups starting next month. Due to COVID at this time, our support groups are going to be virtual, but with the intent of possibly doing them in person at some point. The goal of our support groups will be to address the psychological and social aspects of aortic disease. We all know that aortic dissections, aortic aneurysms, these are rare conditions, and it's really hard to find others, even family members, friends that truly understand what it's like to go through these types of experiences. And so these groups will allow our patients and their families to connect with others that have had these shared experiences. These groups are actually going to start next month. We're going to start with 3 groups. So the first group will be aortic dissection survivors. That will be the first Wednesday of the month from 3 to 4 p.m. Our second group will be those people that are living with aortic aneurysms. So those of you that are involved in our aortic surveillance program, that will be on the second Wednesday of the month. And then the third Wednesday of the month will be for cardiovascular connective tissue disorders. These groups will be facilitated by our registered nurse, genetic counselor, or nurse practitioner. So basically me, Rita, and Chelsea. To register for these support groups, you can go to the Hoag webpage, so hoag.org, under the Heart and Vascular Support Group program. Once you register there, the Zoom link will be forwarded to you, and you can register or participate from there. And without further ado, I'm so excited to announce the newest member of our Aortic Center team, Chelsea Weatherill. She'll be talking to us today about genetic conditions and cardiovascular disease.
Thank you, Meg, for that introduction. I am so happy to be with the team. I've been at Hoag for about 3 years now, mostly working in hereditary cancer, but I've really enjoyed my time so far with the Heart and Vascular Institute and meeting some of you. So today I'm going to talk about the genetics of aortic disease. And to start, I'm going to do a quick genetics 101 review. So in the bottom left-hand corner, we have a cartoon picture of a DNA strand. And you can think of your DNA as your body's instruction manual. It contains all of these chemical codes that spell out the information that your body needs to function. And your genes are just pieces of DNA. So these are kind of like the chapters in the instruction manual. So you have chapters on what color to make your eyes, what color to make your hair, and then you also have genes or chapters that tell your body how to make your heart, how to make your heart work, and all of that kind of information. If we were to kind of open up one of these chapters, zoom in even closer, we could actually get down to the chemical letters. And so there are 4 different chemical letters that make up DNA: A, T, G, and C. And scientists at our genetic testing labs can read through these letters one at a time to check for any sort of errors in the instruction or spelling mistakes. So when we do genetic testing, essentially it's a spell check of these genes related to heart structure and function. So here's a picture of a few of the genes that are related to connective tissue and other various instructions your heart needs. And so to make this kind of simple, if we had a really simple instruction or a simple gene and it said something like pet the red cat, and then someone had genetic testing and they read through their version of the gene that said pet the red cat, we'd call that a negative result because the instruction is correct, the person's doing the right action, they're petting the cat. But if someone had even just a one-letter switch in their version of this gene and it said pet the red hat, now they're doing the wrong task. We wanted them to pet the cat and they're petting the hat. And so this is a very harmful change in this person's instruction, even though it's only a one-letter switch. The same thing happens with the genetic testing for these genes related to aortic aneurysms and dissections. And so this is an example of someone's test result for the COL3A1 gene, and circled there I have the actual mutation or variant that this person carries. So the way we read that is after the C dot, the first number is the position of the mistake. So at letter number 1897 in this gene, a G was switched to an A. So that person is supposed to have a G at that spot, but they have an A. They have a one-letter typo that now affects how their body makes connective tissue and can possibly put them at higher risk for aortic dissection. So when we're thinking about aortic aneurysms and dissections, people often want to know, what are the chances this is hereditary, or why did this happen? And so about 80% of the time we consider these to be sporadic. So they're happening by chance, they're happening from some sort of factor in the environment, such as aging, tobacco use, high blood pressure, injury, acute disease, or inflammation, something that's an outside factor kind of affecting the aorta. In cases of familial or hereditary disease, this is when it can be running in the family. So a hereditary aneurysm or dissection is when there's a mutation in a known gene that put them at higher risk. In cases of familial aortic aneurysms and dissections, we see these conditions running in a family, and it might be either due to a mutation in a gene that we don't know about yet, or possibly due to shared environmental risk factors. If everyone in the family was exposed to the same risk factor, that's a reason it could look like it's running in the family. And so this is just a little picture of our chromosomes, which are kind of the structures that hold all of our DNA. And these arrows are pointing to all of the genes that we know of that could put someone possibly at higher risk for aortic aneurysm or dissection. So if someone comes in and has genetic testing, we have the laboratory sequence all of these genes to check for any sort of mutations or mistakes in these genes. And so most of these genes are inherited in a dominant fashion. Not all of them, but this is the most common pattern of inheritance. So this is the one I'm going to explain today. And so every person typically is born with 2 copies of all of these genes related to aneurysms and dissections. And so in this example, the little blue square represents a normal version of the gene, and the red square represents a version of the gene with a mutation or a spelling mistake. So in this example, the mother carries the risk factor. And so when she goes on to have kids, there's a 50-50 chance that she either passes on her good version of the gene or her bad version of the gene. And then in this example, the father does not carry a genetic mutation, so he only has good genes to pass on every time. So what this results in is a 50-50 chance that either parent will pass on the gene mutation or the risk factor to the future generation. In some families, they have what we call de novo mutations, which means that neither parent carried the mutation to begin with, and they're the first one in their family. It's kind of like a sporadic thing that just happened, and it's the first generation. And then, like I said, not all the genes are inherited this way. This is just the most common type. Okay, so when we think about the hereditary conditions that are related to aortic aneurysms and dissections, we can kind of break them up into 2 different categories, where syndromic is the first category. This means that the gene mutation that's causing the aneurysm or dissection can also lead to other physical features and manifestations in other organ systems. So if you think about kind of our main 3 conditions, these are the big ones you hear most of. The first one being Marfan syndrome. Other features that individuals with Marfan syndrome may experience are severe nearsightedness. The lens of their eye can dislocate. They may have long extremities, lax joints, a concave or convex chest, or a curved spine. With vascular Ehlers-Danlos syndrome or VEDS, we can see thin translucent skin, easy bruising, and organ fragility. So they might be at risk for like a uterine rupture or a colon rupture. And then Louis-Dietz syndrome, lots of features similar to Marfan syndrome. Also in this condition, we can see a bifid uvula, so the little thing that hangs at the back of your throat, it's split into 2 rather than 1. cleft palate, fusing of the skull bones too soon, clubfoot, small jaw, and other features like that. Versus in our non-syndromic cases, this is when the gene mutation that's putting someone at higher risk for aneurysm or dissection is only affecting the aorta and vascular systems, but it doesn't cause any of these other possibly physical features that we could notice. So here's an example of a few of the genes related to non-syndromic dissections. And then we also think there's a lot of genes out there that are yet to be discovered, because we definitely see this running in families with no other physical features, and we don't always find a gene to explain the family history. Okay, so speaking of family history, when we're reviewing your family tree, there's a few red flags that we look for that indicate the history of aneurysm or dissection in your family might be more likely to be related to a genetic factor. And so if someone has an aneurysm or a dissection and they were diagnosed under age 50, so early age at diagnosis means that it might be more likely to be hereditary, or if they're diagnosed between age 50 to 60 and they do not have high blood pressure, if there's a family history of an aneurysm or a dissection, and if individuals have syndromic features related to any of those conditions we just mentioned. So this is actually a family tree diagram for a patient that I saw, and the arrow is pointing to her, and on the family tree, the circles represent females and the squares represent males, and people in the same horizontal row are in the same generation. So she actually had an aortic dissection when she was 53. And to the right of her, you see a square and a circle, and underneath it says heart attack for both of them. That was her brother and sister, and they actually lived in the Philippines. And so she was told they had a heart attack, but we don't actually know if that was confirmed or if it was maybe related to the aorta. Her mother also had a dissection at 66. Maternal uncle has an aneurysm. And then maternal grandparents, her grandmother passed at 50 due to an accident or an unexplained death, and grandfather had a heart attack. So in her family, we definitely see some red flags. We see the dissections and aneurysms running in the family, young ages. And we also, these are things we're looking for. And we want you to know about your family history. So ask your relatives about family history. If someone has something like this, update your doctor. They might only take your family history at your initial establishing care visit. So we want you to update your doctor. So if something like this is in the family, you can get genetic testing and we can identify the people who are at high risk. And so this patient from this family tree did undergo genetic testing. And when you do genetic testing, there are 3 different results you can get back. The first being a negative test result. So this is when no causative mutation is identified to explain the family history of aneurysm or dissection, and which unfortunately means the genetic testing cannot be used to determine which family members have or have not inherited the increased susceptibility for disease. So unfortunately, this is the result that patient from the last slide got. She got a negative result. So even though it's running in the family, it's in her and her mother, we didn't find a genetic explanation. And so that doesn't completely mean that her daughter is now in the clear, right? Because it's still running in the family. And so when we don't find a genetic cause, again, we can't rule out who might not be at risk. So the American Heart Association has guidelines that say all first-degree relatives, so siblings, children, and parents of someone with an aortic aneurysm or dissection should have imaging of their heart just to monitor the size of their aorta. And, if it is getting to the point where they might be at risk for dissection, they can go in and possibly repair. The next type of result we get sometimes that is really frustrating for people is an uncertain genetic test result. So this is called a variant of unknown or uncertain significance, or a VUS. And this means that they found a variation in the aortic disease gene, but they don't know if it's putting someone at higher risk for an aneurysm or dissection. So if we go back to our example from the beginning, where a negative result with this particular gene or instruction is pet the red cat and a positive is pet the red hat, an unknown result would be like if the C was switched to a K, right? If you read the word KAT, you pronounce it as cat. And if a child wrote you this instruction, you'd know they probably meant to pet the animal, the cat, but we don't know for sure in the cases of these genes whether or not a change like this might be disease causing or it might be harmless. So these are tricky because they can't really also be used to inform who might be at risk in the family, because we don't know if it's actually the cause of the dissection or just kind of an incidental finding. So with these, we continue to research them. We check with other labs. Sometimes we refer people to research studies that can study their variant to try and figure out whether or not it is the cause, and then, test the appropriate family members. Okay, and the third possible result is a positive result. This is when we do find a mutation in one of these genes, And then we follow up with surveillance. So someone might be watched by a geneticist, a cardiologist, a surgeon. They do imaging of the aorta every year to watch the size of the diameter. They might take medication to lower risks, control the high blood pressure, avoid other risk factors like smoking or straining, weightlifting, things like that. And then if it does get to the point where they're at risk for dissection, again, one of our doctors could go in and do a repair to try and avoid emergent dissection. And so sometimes people do this testing if they're, in the stage where they're monitoring and they might at some point need a surgical repair. The testing sometimes can help us decide at what diameter the surgery is indicated. So these are some of the guidelines here on the right, where, for example, with Marfan syndrome, when the diameter of the aorta reaches 50 millimeters, that's when they consider it's maybe time to think about surgery, versus like with the ACTA2 gene, they might do it at 45 millimeters because people with that might dissect at a smaller diameter. And so other things to consider, though, is if someone's aorta is growing at a rapid pace, or they have a history of relatives who dissected at a smaller size, then they might consider doing repairs sooner, but these are kind of general guidelines. So genetic testing can just definitely help the people that are in the watchful kind of waiting period to maybe help guide when surgery is needed. Okay, so finally, a lot of people want to know, what's the cost of genetic testing? Is this even feasible? And so it is often covered by insurance when criteria is met. So if someone does have those red flags in their personal or family history, like young age, multiple relatives with a history, insurance likely would cover the testing. Right now, there is a laboratory offering free genetic testing for aortic aneurysms and dissections for Medicare, for individuals with straight Medicare. For non-straight Medicare plans, like HMO plans, it's usually around $100 or less. And then for people who don't have insurance or don't meet criteria, the out-of-pocket cost for this type of genetic testing is about $250. And so even if someone doesn't meet criteria, but they still want to do testing, we definitely allow that, and we can help coordinate that. Also, a lot of the labs have a policy where if a mutation is identified for a relative, they'll test all the blood relatives for free for about 3 months. So we can help coordinate sending saliva kits to your relatives to help get them tested to find out if they also have a risk. I have Meg's number on here. She said we can call her to schedule if someone's interested in coming in for genetic testing or a genetic counseling appointment, or if they feel like maybe there also are syndromic features in their family, they can also see Meg and Dr. Liang for a full exam. But yeah, with that, I'm going to hand it back over to Dr. Caffarelli for our Q&A period.
Thanks for that, Chelsea. What a great talk, and by everyone. We've gotten some questions in through the chat line. If we could have the media folks throw everyone up on the sidebar, that'd be great. One of the first questions, we'll start easy and then go hard. So Dr. Liang and Meg, how or what got you interested in the Marfan and connective tissue population?
Well, some of it's a little bit of serendipity, it's opportunity. And I think more of the question is what kept me involved. And it's actually the community. It's the people are wonderful. I've been involved very much with the Marfan Foundation for many years, and the opportunity to meet with the patients and their families and really be a part of their families has really been what's kept me involved. And it's kind of cool science as well. So with that, I'll ask Meg what got her involved, besides Tony calling her.
Well, it's no secret really that I have a cardiovascular connective tissue disorder, as do my 2 children. So I have vascular Ehlers-Danlos syndrome. Was diagnosed later in my life, but I realized real early that with a rare disease that we needed folks that understood these conditions in our medical community, and I figured I could do my best work as a nurse in this type of role, because I do get it, and I love being able to advocate for our patients and for our patients' families. So that's how I got here.
Perfect. And we're glad to have you guys. On that same note, someone asked, are there certain ethnicities that are more prone to get Marfans?
Speak up, Chelsea. Go for it.
Oh, I thought you were going to answer.
No, you're the geneticist, not me.
Not that I know of, but correct me if I'm wrong.
No, that's correct. Yeah. As far as we know, there does not seem to be any particular ethnicity. It does present itself somewhat differently depending on ethnicity. So obviously, African Americans tend to be more prominent because they're taller and longer than to begin with. So when they have the mutation, it becomes much more apparent. If you take someone like me with short, stumpy limbs to begin with, it's not as apparent when it happens. But the actual frequency is about the same as far as anybody knows across all ethnicities.
Okay, Chelsea, I got one for you. How long is the wait for genetic testing for the appointments and then the results? We kind of already touched base on the cost.
Yeah, and they're like Meg mentioned, I think on Thursdays and Fridays. Right now, I don't really have a wait for genetic counseling and testing. And then after we collect your saliva or blood draw, it's about 3 to 4 weeks for results.
Perfect. And on the same genetic disorder results for Dr. Shah, is surgery on patients with a genetic disorder different than surgery on a patient that's not syndromic?
Yeah, that's a great question. And it definitely can be different. So the tissue is, inherently a little bit weaker. So one thing, our handling of the tissue, we do a little bit more carefully. Maybe we do a few more extra maneuvers to support the tissue, especially where we're sewing the graft, the patient's remaining tissue. Next, we'd be more likely to replace some more of the aorta in that initial setting. For example, if we knew someone had Marfan's or Louis Dietz and their A setting was enlarged, while we're in there, we'd probably replace the root 2 disc because there'd be a very high chance of needing that repaired or replaced in the future again. And we wouldn't want them to have to need a second surgery so quickly after their first one.
Yeah, I would agree with all that. And I always tell my connective tissue patients, there is an upside for the connective tissue disorder. And that is if we need to do a second surgery for a stage procedure, the scar tissue isn't that bad. So there's always an upside, just depends on your perspective. So with that, that ends some of the Q&A that we've gotten. I want to thank everyone on the online community for joining us on this Sunday afternoon. Next year, September 19th on a Monday evening. And I plan on being on the parking lot up on the top deck in the south parking lot. So I look forward to having you there. Our team will be a little bit bigger by then. And I want to thank all the speakers. It's a privilege and honor to work with you every single day. And look forward to seeing you tomorrow morning. So with that, we're going to end today's events. And thank you very much.
Thank you.
Thank you.
Thank you.